what we get will be QS, and therefore the T So we are seeing T wave tall in all the leads. It is not specific. So that gives me the clue that the problem is in the blood. Blood means it is hyperkalemia. So this particular ECG what we are seeing with a tall tented walking T wave, all of the chest leads and the limb leads and the precordial leads is a hyperkalemia. So with this basic thing, so I just wanted to give you some examples as to this is what we are going to solve, this is what we are going to read. So we start with the basic principle of what is it will be 0.5 milliwatt and therefore 2 large squares would be 1 milliwatt, and this is on the vertical axis. On the horizontal axis it displays the time. So therefore 1 small square is equal to 0.04, that is what I mentioned with the URS also. So 1 small square is equal to 0.04 milliseconds, and therefore you have 1 large square, that is 5, will equal to mean 0.2, which is equal to 200 milliseconds, and therefore if you have 5 such big large squares, you have 0.2 into 5, that will give you 1 second. 0.2 into 5, that will give you 1 second. And why this is basic, but this will have to be remembered because you want to calculate the heart rate, and then of course the problem starts whether it is a regular heart rate or an irregular heart rate. So therefore immaterial of that, if we remember that it is 1 second, so if we want to multiply it by 60, we would get the heart rate. So if we want to calculate the atrial heart rate, if we will see the PP interval, if we want to see the ventricular heart rate, we will see the RR interval. So PP will give the atrial rate, RR will give the ventricular rate. These are basics which we will have to remember, and therefore we will have to go through all these. And then of course this is the spatial orientation of the ECG leads, and therefore some intervals we talk. In the reference you can see the blackboard I have mentioned. The first is the PR interval. The PR interval, normal. There is a facility to freeze the screen. You can then count the number of boxes, that will give you the heart rate. Again it is immaterial whether it is regular or irregular because we are counting from the number of seconds. So you will be able to calculate what is the heart rate, whether it is regular heart rate or the RR or the PP, or if you want to measure the rate. So again I pose this problem to the postgraduate in medicine. If in SVT where the heart rate will be plus 150 or the VT where the heart rate typically will be anything between 200 to 300, I cannot expect the P wave to be seen. You will only see complexes. We will show you a ECG of the SVT and VT also. So there this monitor comes in here and there this screen comes in here because, and these are live examples. In my residency I remember I got the collector's mother admitted with SVT. 10 helpers and MAP, all of them breathing down your way, SVT, heart rate 150, and that time I got a VT from an anterior infarct. So therefore definitely I will be wanting to pay attention to the VT, whereas a political problem will be that no, you have to address this first. So you can have that, and therefore how do I diagnose whether it is a VT or SVT? Both heart rate and plus 350. So again when the heart rate is more, what usually happens is when the heart rate is more, the cardiac output is less. If the cardiac output is less, the BP will fall. So usually you will find that anybody who is treating is confused as to should I wait and give time for the BP to pick up so that I can do an intervention. Because in his mind it is running, should I give emetron, should I give adenosine, should I give Zalopard? So that will be running in his mind. So but in these kind of situations, the answer is cardioversion. It is going to correct the SVT also, it is going to correct the VT also. But yes, you have the choice of adenosine, or you have the choice of Zalopard, or you have the choice of Mexilidine, to put as a So in this particular situation, I did the carotid massage for or the collector's mother. So she set it, and then of course I put in some adenosine. So the practical, okay, everybody knows that the treatment for HPT is adenosine, but adenosine he says 6 milligrams is equal to 1 ml. So you imagine that the angiogram that is put here, so the angiogram duration that 1 ml will be put in, will be kept in the ventricle in the angiogram only. It is not going to read. So therefore, this simple practical tip at the bedside you will learn is that you should first start a IV line. You should start a IV line. You clamp the IV line, give this 6 milligrams adenosine as a bolus, and then run through the IV fluid so that it will not stay in the cannula, and through the circulation it will reach and give prompt response. So that is how one will have to handle. So coming back to the ECG paper and the cardiac monitor, so my step would be that the monitor speed we should increase from 25 millimeters to 50 millimeters. But purely you will see that it is sinus. So clinical importance is, see again it has pointed out here, it is less than 4 seconds. So that is what will decide whether it is a sinus pause or whether it is a sinus arrest. So therefore, the clinical importance is that if it were happened to with a ventricular premature beat, then you know that the property is that P wave will be absent in a BPC or a PVC or a BPC is absent, and it is followed by a compensatory pause. So again I am sure we will show you in the ECGs that there is grading of ectopy. These ectopics, they can be occasional, means in one frame or one 25 millimeter frame, 5 seconds, 6 seconds, we are getting only one ectopic beat. Or it is possible that I can get two ectopic beats together. So then it will be called ectopic couplets. But the clinical importance is that when there is a ectopy, it is not, the blood is not going to reach the brain. And therefore, we have the next question, what is Stoke-Adams syndrome? Last bench. What is Stoke-Adams syndrome? Last bench here. What is Stoke-Adams? What is Stoke-Adams? Ready to go? Then it will fall. Somebody from medicine will have to elaborate. Can you please pass the mic? One of the medicine. One of you tell what is Stoke-Adams syndrome? यार इतना लेटेड टाइम मेरे को पसंद नहीं है.
Loss of consciousness due to decreased cardiac output.
Perfect. Yeah, he deserves an round of applause. High pulse rate of a sinus tachycardia, and that if it is less than 60, it would be sinus bradycardia. We have talked about P waves. It can be abnormality. It can be that P wave can be absent. Like you mentioned, the first degree heart block, the PR interval is prolonged, and then of course P wave can be absent in sinus arrest, or when we give drugs like digiplex and cholinergics. The PR interval lengthening will be with the heart block, starting from the first degree heart block, to a prolongation of the PR to a complete dissociation of the P and the QRS. That would be the complete heart block. So this is how it is. This is the speed of the ECG paper which we have covered. So the learning objectives of our program is to recognize the normal waveform and know what physiological event each represents. Identify intervals and segments and understand the basic significance of the abnormality levels. So with this I feel that the understanding of the basics has been covered. So then we should actually come to the Eindhoven triangle. So the commonest problem that an intern will face is you want to record a ECG and you have somebody with an amputated leg. So how does one record a ECG from today's program, we can get a cross section, one or two candidates from each row to tell us what is their expectation on this program. We will start from the extreme right. What is their expectation from this program? Anybody of you? I can identify Shruti. You want a mic? The mic is somewhere here. Come on, mic is changing. Yeah. Middle row. Last bench. When we are talking of constipation, and that is what the surgeon or maybe the gynecologist would like to remember, that this will be the commonest thing. Our focus will be only on the urine output and the IV fluid intake output matching, but we tend to ignore the electrolytes. Now, the practical problem, the credit goes to the medicine PGs. In the past week itself, we have diagnosed maybe 4 or 5 hypokalemias presenting as quadriparsis. But we know that extreme summer, we are losing water. Everybody, the common man will think that we are losing water. But in that water, we are also losing electrolyte. We are losing sodium. We are losing all the electrolyte. Add to that, if somebody has given some RMP or somebody has given any diuretic, so therefore side effects of diuretics we teach is hypokalemia, hyponatremia, hypomagnesemia, hypomagnesemia, everything, hypocalcemia. So the patient ends up with we had the extreme case quadriparsis presenting hypokalemia presenting as quadriparsis and paraparsis. We had these 5 cases in the past week. So that is the learning that you simply see study, correlate, and you have the answer. And they gave what of course collaboration in the biochemistry. Once you see that this is hypokalemia, so all this is what we will learn from the ECG. This is what all we are going to get. So coming back to the question, if the amputated limb is there, where will we place our lead? Anybody in the heart, except of course medicine. Except medicine. Can anybody tell if the right lower limb is amputated, how are you going to